next speaker. So our next speaker is another young bright star, Dr. ANAMIKA Patel. She belongs to the group of young ophthalmologists and is specialized in vitreoretinal diseases, uveitis and ocular immunology from Visakhapatnam campus of LV Prasad. And she is going to talk on another complex topic, subretinal fibrosis in uveitis. On to you, Dr. ANAMIKA.
Thank you, Dr. Chitra, for the kind introduction. And I would like to thank the ARC to have given me the opportunity to share some points on subretinal fibrosis and uveitis. So as intriguing as it may sound to you, let me take you through the very 7 questions through my presentation, which would aid you to navigate through the concepts of the subretinal fibrosis easily. So the first question that we have with us is that, is subretinal fibrosis really a clinical diagnosis? Well, the answer to the question is that it's a clinical sign and it does not represent any particular clinical entity. So now that we understand that it's a clinical sign and it's not and it does not represent any entity, so what are the morphological characteristic features of the subretinal fibrosis? So since this is the question number 2, I would like to take you through 2 points. First would be that you look at the color, and second would be you look at the location. So when I speak of color, the color is white. Now there are different shades of white that you get to see. So you'll see it appearing as white in color, as you can see beautifully how it is picked up in this photograph here. With that, you may see the presence of the pigmentation, which could be very subtle and sometimes very prominent, as you are seeing in this chronic central serous choroidal case. So I spoke about color, that you have to look at the color, which is white. The second point is about the location. So macula and the peripapillary region are most commonly involved. Nevertheless, the mid-peripheral region of retina can also be affected. So the third question would be that, is it always associated with the posterior uveitis? So it's not the case, because there are certain conditions where you can see the presence of a subretinal fibrosis. Let's say neovascular age-related macular degeneration, where you get to see the scarring, or the choroidal neovascularization from any cause, or proliferative vitreoretinopathy. And the fourth would be the presence of a chronic RD. So this is the case of a subretinal fibrosis in a chronic central serous choroidal, where you can see the presence of this nice subretinal fibrosis with the shades of hyperpigmentation here. So now we have gone through the 3 questions so far, and let's move on to the 4th question, that what are the commonest causes of subretinal fibrosis in posterior uveitis? So the image that you are looking at here, so I have tried to sum up the 6 very important and common causes where we get to see the subretinal fibrosis in posterior uveitis, starting with the ocular tuberculosis, then serpiginous-like choroiditis, punctate inner choroidopathy. What you can see here is ocular sarcoidosis, VKH, sympathetic ophthalmitis as well, and idiopathic progressive subretinal fibrosis. So now the question that comes to mind is that, is it a sequelae or it is a primary presentation? So let's take a look through these different clinical scenarios where it will help you understand that how it really happens. So this is a case at the presentation wherein you see this young gentleman who presented to ROPD with this nice contiguous retinal vasculitis and the presence of these hemorrhages here. The diagnosis of ocular tuberculosis were right in hand, duly treated in time. And now over a period of years, what you're looking at around the disc is the presence of this hypo and hyperpigmentation, which is nothing but subretinal fibrosis. So the point what I'm trying to strike out here is that this is happening over a period of time. Another point is about a case of ocular sarcoidosis. This presentation had the intermediate uveitis at presentation, where there was this disc, very prominent disc edema in both the eyes. And over a period of time, how it developed. And remember the white color that I was trying to speak, the morphological characteristic that you are looking at. Another clinical scenario would be presence of the punctate inner choroidopathy, where this kind of condition is seen mostly in the young myopic patients, where over a period of time you can see the subretinal fibrosis setting in. Another very interesting, and I think all of us know about the SLC. So some patients, they may get to develop the presence of the subretinal fibrosis here. In almost about 35% of the patients would get to develop that because of the presence of choroidal neovascularization. Another presentation would be where you see a multifocal choroiditis-like presentation where you see.
We are not seeing the video.
This
Video is not seen.
Why is that? We are all able to see. Dr. Ratnam, maybe your network is not strong or what? Okay, you carry on.
Thank you, Dr. Namamurthy. All right, so I was speaking about a case of a multifocal choroiditis with a subretinal fibrosis presentation, where when you look at the ICG, it nicely picks up these hypodots which are there. But the FA, if you compare, it nicely shows you the border of a subretinal fibrosis as a hypofluorescent with in the midst of that, you see the presence of a choroidal neovascular membrane, which is hyperfluorescent. Another case where a disc edema and a peripapillary choroidal neovascular membrane is seen. There, this we had a differential of TB versus sarcoid as a presentation. And as you see, once this patient was started showing the sign of resolution, this nice, cuff of a peripapillary fibrosis was setting in. Another same case which shows the same thing happening. And this is another patient, a 16-year-old female who post-corneal tear repair in one eye, presented with a sympathetic ophthalmitis in one eye. And over a period of time, she did develop a choroidal neovascular membrane and the presence of a subretinal fibrosis. So as we know, VKH, well, they can present with a bullous retinal detachment, and when they are in their chronic stage, you can see this various shades of pigmentation, either this like what the white that I was speaking of, or the hyperpigmentation. This is another chronic stage presentation of the VKH, where you can see the presence of this nice white plaque-like thing, which is brightly, nicely seen in the OCT. See a myopic presentation as well in the VKH, and in such cases, if you get to see a presence of a subretinal hemorrhage, that would indicate the presence of a choroidal neovascular membrane. So in last few minutes, you have been looking at the peripapillary choroidal neovascular membrane happening, that leading to the subretinal fibrosis. But here is a case where this white cuff-like thing was present at the presentation. And over a period of 4 to 5 years, the patient has developed the subretinal fibrosis with the pigmentation. And the same patient, other eye, had this choroidal neovascular membrane. And lastly, I would like to take you through the idiopathic progressive subretinal fibrosis, where you can see the presence of a choroidal neovascular membrane as well. So now the question is that there are questions that are associated with the posterior uveitis, but does that denote the active inflammation? So the answer is no, because it could be because of a choroidal neovascular membrane, because a presence of an intraretinal fluid, if you get to see on OCT, that would indicate that the subretinal fibrosis is possibly due to the CNVM. The last question is that what is the best treatment for subretinal fibrosis? And it's an age-old saying that we know that prevention is better than cure. Why I say that is because once a subretinal fibrosis sets in, really nothing can happen, because it leads to the irreversible structural changes in the photoreceptor layers. So best is to pick them up early and treat the patients. Still, if you would want to take the aid, you can go ahead with the systemic and local steroids, anti-VEGFs for CNVM, and immunomodulators for the other diseases that are associated with that. So what we have learned today is that subretinal fibrosis is a clinical sign. You have to remember the 2 points. First is color, that it appears white in color. And then you have to remember the location, that macula and peripapillary region are most commonly involved. Now, there are various conditions which would lead to the subretinal fibrosis and posterior uveitis. But if you get to see the presence of intraretinal fluid, that means it is because of the CNVM. And lastly, prevention is better than cure. So this brings me to the end of my talk. Thank you so much.
That was wonderful, Dr. ANAMIKA, the way you split it up into so many parts and made it a very useful information for us. So, so if you see a macular scarring in one eye and minor lesions in the other eye, you would get very aggressive in your management, I'm sure, right?
Yes, Dr. Murthy. Yeah.
What is the role of autofluorescence in these cases of subretinal fibrosis?
We do not really depend on the autofluorescence role. It's just one good way of imaging that, but it does not really help us to go to differentiate first or to take ahead with the treatment. It does not really help in the management aspect. The point
Maybe-
what is important is that you pick up what is causing the subretinal fibrosis, the associated condition, the like what I was saying, that first you need to differentiate that is uveitic condition or non-uveitic condition and treat accordingly.
Yes, Dr. Avinash, your thoughts?
No, I just have a question to Dr. JB and Dr. Vaishali and Dr. Ratnam. So in all your extensive clinical practices, so we all know that prevention is the best form of treatment for subretinal fibrosis. So is there any condition where non-choroidal neovascular subretinal fibrosis you can preempt, and then these are the signs which would help you to pep up or step up the steroids or immunosuppression so that these patients would not land up in extensive subretinal fibrosis? Do you have any clues where you can share with the rest of us?
Yeah, very good I'm sorry, you proceed, sir.
No,
Yeah.
you go ahead.
No, very good immunosuppression definitely lessen the incidence of subretinal fibrosis. Proper immunosuppressive in proper dose and proper duration definitely reduces the incidence. Do you agree with me, sir?
I find that in the VKH patients, if you don't treat hard at the beginning, if you don't give IVMP at the beginning, they lead to the chronic stage and go to the subretinal fibrosis. So the prevention is the better. Treat very hard at the initial stage. Once subretinal fibrosis develops, I don't think that you can do anything further.
Yes.
Dr. Vaishali?
To add to whatever has been said, to me, there are two components of subretinal fibrosis. One is diseases like Dr. Biswas said, VKH, sympathetic ophthalmia, and another one which was missed is multifocal choroiditis with pan-uveitis.
Yeah.
Now,
I didn't mention that, Dr. Vishal.
So these are the kind of entities where I would just go with biologics, and if patient develops fibrosis, I take it as a personal failure to treat. Patients with TB, sarcoid, BKH, and all these should not develop fibrosis if they are treated adequately. The second component is the part of SHREM. Now, SHREM, like she showed in PIC and other beautiful peripapillary CNV. And we have recently reported that when we look at subretinal hyperreflective material, which is SHREM reported in AMD, we did find that 60% of them do have underlying neovascularization. We allowed to not treat and randomize to treatment, and over a period of time, we realized that if OCT angio is showing some abnormal new vessels lurking beneath so-called fibrosis, it's a good idea to treat them to reduce the progression of scotoma as well as the progression of the entire subretinal fibrosation. Thank you.
Dr. Srinivas, anything to add?
Can I make a comment?
Yes.
Go ahead, Rohan sir.
Yeah. Very nice presentation. And I think the way you put it, as you describe it as a sign, then I think everything fits in and you can describe it well. But I think if we take the typical uveitis textbooks, then the subretinal fibrosis, what we read would rather fall into that idiopathic subretinal fibrosis syndrome part of it, or when it occurs after severe uveitis, like ma'am said, after multifocal choroiditis or relentless serpiginous choroiditis. So I think we have to separate these two. One is general subretinal fibrosis and one is a severe uveitis related subretinal fibrosis, because that would require the stronger immunosuppression, as everyone has mentioned. And the other one is probably just part of the SHREM or something. So I think the slight difference in the entities, if we take a very typical definition.
Thank you.
Shall we, Srinivas, shall I go on to the next speaker?
Yeah, one quick question. Avinash sir, I wanted to just ask the same question which you asked, where we usually try to, we all know that once the fibrosis set in, then the effect of the steroids usually comes down, and we usually use the immunosuppressive drugs more. So should we continue using the steroids even though the fibrosis has set in? And secondly, some reviewers or authors have even used the anti-VEGF along with the immunosuppressive therapy in treating and halting these fibrotic changes. So do we have to use only if there is a CNVM component which is getting complicated, or even in these cases also extreme diseases, we can still use the anti-VEGF along with the immunosuppression?
So thanks, Srinivas. That's a very important question. The first answer to the first question is, if there is fibrosis, do we have to tailor make the steroids, right? So
Yeah.
I think to be very precise, to give a very precise answer to the question, the influence of immunosuppression should not depend on the pre-existing subretinal fibrosis, right? It should depend on the amount of intraocular inflammation than pre-existing subretinal fibrosis. The second point of it, do we have to manage the neovascular component as well in subretinal fibrosis? Yes, many times there will be a neovascular component, like what Dr. Vaishali was mentioning. So there would be some vascular component which will be there, which otherwise we could miss. But on Octa, we see them far better than fluorescein, because fluorescein is sometimes difficult to pick up those very tiny blood vessels. But having said that, when a patient presents with subretinal fibrosis, these are the mature vessels which not make considerable change even after you administer an anti-VEGF. So they tend to persist the way they are. And if that's the reason why prevention is the best. If the fibrosis already set in with no accompanying hemorrhage, administration of anti-VEGF may not be of great relevance in either decreasing the size of the fibrosis or preventing in the increase. So again, presence of hemorrhage or intraretinal fluid may have some influence, but if it's not there, just because you see some vascular network on Opta, that should not influence someone to treat with anti-VEGF.
Avinash, you combine that with the flow. You also look at the flow in the B scan, and if the flow is more than 40% of increase, then we followed them up for 1 year, and then anti-VEGF does help. Not that any vessels you see on Octa you start injecting. It has to be combined with increased flow on OCT.
Thank you very much for all the inputs. We should, because we have to cover whole